Soltermann about the diagnostic approach.
Yes. Good morning, everybody. I was asked to give you some insights about our diagnostic process in this hospital. So first part is certainly the immunohistochemistry. And as you heard, tissue is the issue. Today I want to present you something. Cytology, cells are the issue as well. So case here, so this is a female patient, 60-year-old with 50 PEC years, and she came in October 2015 with an advanced lung adenocarcinoma CM1A stage 4 because there was pleural infiltration with carcinosis, massive effusion, and lymph node metastasis. Now in such case, actually what happens here often is that there is no biopsy actually done. It's only cytology, it's only the effusion, the pleural effusion, which is taken and used for the whole diagnostic process. So we obtained two samples of 10 ml and 2000 ml from the malignant pleural effusion. And then we always do a smear. We have 3 smears. The problem is that you have only 3 smears, so you can't do much on this. And that's why we have established 10 years ago actually an alternative method which is called cell block. So the cells can also be clotted into a cell block, and a cell block can be cut. You can make 100 cuts for all the relevant markers. And there a TTF1 positive lung adenocarcinoma was diagnosed, and MOLPAT found a KRAS mutation. She had ECOG status 0, and therefore on our tumor board, it was decided that she would obtain cisplatin pemetrexed in October 2015. So now here you can see the first step of the whole diagnosis. Here is the smear. The smear, the cells are fixed with Delaunay and stained with Papa Nicolau. And you can see here the typical gray pair of the adenocarcinoma. Also with here these vacuoles here, so actually you don't need much IHC for this. This is adenocarcinoma in the pleural effusion. And then, so here the second step is now a cell block. The morphology looks a little bit different, but still good. And you can stain it first with H&E. Again, here, this is a typical adenocarcinoma surrounded by immune cells. Now then, what happens? This block actually goes into the archive in October then. Yeah? Then it's important to think about that 3 months later, I was asked to perform an additional marker, PD-L1, on this archive block. So we retrieve the block from the archive, and we actually can continue our whole diagnostic procedure. So that's what I did then in January 2016. So at the very beginning of PD-L1 IHC with the cell signaling antibody E1L3N on a LICA-bond platform on this very same cell block. You can see here the malignant cells. There are some of them. And now, as a pathologist, you need to make a report. So what shall I write now in the report? Because it's important, it gives you an idea into which direction to go. Somebody has a judgment? Difficult judgment on this magnification. You may think about, well, here there is some blush of brown, as Keith Kerr in Aberdeen would say. Then, well, what I can do is we go closer inside, and then it looks like this. So certainly some of the adenocarcinoma cells have here unequivocal membranous activity, immunoreactivity for PD-L1. So I decided then in January 2016 that it is weak, but this is more than 10% of tumor cells, and this gives then, according to the new guidelines, category 3. Huh? You have heard about this, the German PD-L1 harmonization trial. It is important because you have the different drugs, the different antibodies, the different platforms. And for example, pembrolizumab, as you can see here, it clearly gives you the cutoff of 50%. Huh? Category 3, as you can see here, is in the Cologne score is above 10. However, category 5 is above 50%. So this patient actually, she would not qualify for pembro according what I did. So then my thing was in December we had a meeting for a Swiss harmonization trial of PD-L1. So I wanted to know how reproducible is that what I'm doing here. And I retrieved the very same blocks again, and I repeated the very same IHCs again. Yeah? Now, to do this, you need controls. The control today is the tonsil, which, as you can see, the crypt epithelia, they are always positive for PD-L1. And there is some minor positivity in these immune cells of the germinal center. So that's how it should look like, and that's acceptable. But surprisingly now, what happens is if I take now the very same cell block again out 10 months later, it seems that this block somehow has maturated over time, like red wine, a little bit. What happens here now is if I do the same antibody from cell signaling, actually all of these cells become positive, so it has shifted now from category 3 to category 5, just in the archive. Yeah? And then, okay, I said, okay, I want to have, we had two cytology samples, we go for the other one, it presents the same. And then you heard the discussions about the best antibody, so then we go for Ventana, the proposed best antibody, SP263, which, as you can see here on the tonsil, is definitely already stronger on the crypt epithelia. And now if you stain again, the very same cell blocks here for effusion 1 and effusion 2. Effusion 2 already here, you see that the problems of IHC, because you clearly see here that next to this membranous immunoreactivity, you definitely have here also an increase of cytosolic immunoreactivity, which officially does not really count. So in conclusion, actually this patient, she has rather a category 5 score, so above 50%, and actually now she would qualify for Pembro, according to the official guidelines. Just to give you an idea about the follow-up, so palliative chemo first stopped due to side effects of peripheral vascular disease. I said PD-L1 is above 10% in January. Then there was tumor progression in March. And then still, it's important to say, in April 2016, she obtained palliative immunotherapy with nivolumab. Until now, 20 times, to say. Side effects, no. ECOG status, still 0. CT in July and PET-CT in October, stable disease. And I said now here in December 2016, PD-L1 IHC is actually above 50%. So that's the typical case that has developed now during this year. So first conclusion here shortly is that the IHC markers for ALK, we have a reliable antibody. For ROS1 is more difficult, but the protocol has been improved. c-MET, there is also the SP44 is reliable, and PD-L1 still, the best antibody still needs to be defined. Now the question is for these malignant effusions, just very shortly. I mean, these are interesting liquids. Actually, as you can see, there's a new paper here by Clive Thorax paper here, which is actually interesting, saying that the lung adenocarcinoma has the worst prognosis. So you could think about establishing also such personalized protocols for malignant effusions. And we have here inside university, the University Research Priority Project, dealing with primary cancer cell lines. And my PhD student David Wu is working on this for the moment. So for example, they have different immune profiles. So mesothelioma actually has more CD8 in the effusion, then whereas the carcinomas have more CD4 and CD25. So you can see here the sediment. Here we take these cells, and this gives us then here the cell clot that we stain for the cell blocks. One can also do, I did once a study on clinical chemistry. One can also do mass spec. You can detect, for example, here I detected an EMT marker, periostin, in the pleural effusion. And so for the moment, what he is doing is we are doing now tissue microarrays out of cell effusion blocks. Here is an example stained with PD-L1 with the Ventana antibody. That works nicely. You can see here these grapes of lung adenocarcinoma surrounded by immune cells. And further, we take now the liquids into, want to go for microtumors. Here's a case of stomach carcinoma with the hanging drop method. You can mix them up with fibroblasts in order to create microtumors that you can actually, where you can apply different drugs. For example, for the moment we give cisplatin Taxol, and we'll also give nivolumab. And here you can see how that looks like when you section it. So here is the cell block. That's the primary cell block. Then this is the 2D culture from the fusion, and then on the right you have the 3D microtumors after the hanging drop method. You can see here the carcinoma cells surrounded by fibroblasts, and that works also for melanoma, for example. Here is the primary cell block, and you can mix them up with fibroblasts, do a double chromogenic IHC, as we can do, melan A plus MIB1. And so these microtumors, of course, can be further used for drug sensitivity, drug testing, and assays. So many thanks for your attention.